Okay, so causal structures. Here's the terms that we're going to go over. Terminal outcome, and this is really my idiosyncratic term, so I just wanted to highlight that. Surrogate outcomes, composites, and competing. So all of these have to do with some designation in a causal framework. So I put a simplified causal diagram here. We have genes, exposure to tobacco smoke, which leads to airway inflammation, which can lead to decrements and measurements of lung function. That's an FEV1. If you continue to expose yourself long enough, you could potentially, and you have the right susceptibilities, develop COPD, which can lead to disability and even COPD-related death. So a terminal outcome, or the way I visualize that, is a clinical outcome at the end of a causal pathway, and this should really say a causal pathway of interest to the investigator. And this is where you're usually trying to apply your MCD, or what you're trying to validate to a grant funder or an audience, that and convince them that this is a valid endpoint, and that any change you're looking at is a valid degree or quantity of change. Where this term becomes a little nebulous is in the fact that what is terminal? Where is the end of a particular causal pathway? And really it's the investigator that decides what the end of the pathway of interest is that they're studying. So if I'm really if my intention is to study the tobacco smoke's effect on lung function, then this is the pathway of interest, and this is the terminal outcome of interest. Now again, there are other outcomes beyond this, and unintentionally, intentionally, or my underlying hypothesis might be a future study towards other endpoints of interest, such as COPD and disability, but for a current study I may only be interested in this part of the pathway. So a little bit semantic, but I think helpful just as some jargon to clarify what you're studying and differentiate it from the next type of outcome, which is surrogate outcome. So a surrogate outcome is not the terminal outcome of interest, but it's associated with that terminal outcome of interest. So again, in this pathway, I'm interested in studying tobacco smoke, and I'm interested in studying its effects on FEV1. But let's just say, for example, in my data set, maybe it was given to me because I have no resources, all we have is self-reported tobacco smoke and self-reported cough. And in this we have cough is the surrogate outcome to what I'm really interested in. And it may or may not be associated with declines in lung function, and there may be different degrees into which it's associated, meaning the strength of the association. So in this sense, it's a surrogate outcome because it's not the terminal outcome of interest that I want, it is rather associated with that. And often these are in reference to biomarkers or physiologic markers, psychometric scores, predictive scores, but sometimes they can be associated with the outcome. They can be a clinical event as well. First, for a good surrogate, it should be strongly associated, so the association should be really strong, and that can be measured. Maybe it's measured in other studies, or you have to do the work yourself. It should be associated with minimal confounders. So are there other things in this framework that cause cough, such as the environment, other things that would help make this more of a confounding situation here. And then ideally, the association is actually inside or within the causal pathway. So what do I mean there? So in this framework that I've drawn here, airway and inflammation damage is a necessary precursor to a decrement in FEV1 or lung function. Whereas cough is not inside the causal pathway, it is just simply associated with decline in lung function. So in this sense, airway inflammation is a stronger surrogate because it has a stronger association. There still could be potential confounders, of course, but it's also inside the causal pathway, so there's more biologic plausibility to this association, that one begets the other. Alright, so let's talk about competing outcomes. So a competing outcome is an event that prevents or impedes the outcome of interest from occurring. So in this sense, it's often described in survival analysis. So if I am studying tobacco smoke in lung cancer death, you have to survive these other causes of death to even achieve this outcome. So in this sense, if you have another cause of death, this becomes a competing outcome. It prevents the lung cancer death from happening. So the importance here, there are other classes that are going to discuss how to address this, and we're going to talk a little bit about it later in the course. I don't have, it's not the intent of this course to go in depth on how to assess this statistically, but there are, if there are competing events, there are statistical methods that allow you to estimate the association of interest while accounting for the competing events. Now, it's not only in survival analysis where this becomes important. I put this as a second point here. A competing event I also think of as something that hinders the assessment of the association of interest, and I'm going to come back to that in a second. Here's just another example. Say I want to look at chemotherapy and its effect on the decrease of tumor size. However, death in this causal structure is a competing outcome. If you die before we can even assess the tumor size, we cannot assess, this event never actually occurs. Here's an example of where it hinders the assessment of an association of interest. So say I'm looking at an anti-epileptic drug or an anti-seizure drug, and I'm interested in looking at its association with grand mal seizure. Now it becomes difficult to purely study that association if other outcomes occur during the study time. For example, what if there's side effects due to the drug and the drug is withdrawn? It makes it difficult to fully assess that association. That's why I call this hindering the assessment of the association of interest. If other more minor seizures are occurring during the time period and another physician, if it's allowed in the study protocol, adds another type or class of anti-seizure or anti-epileptic drug, that makes it again difficult to purely study the association. So it's an event that hinders the outcome. There's different ways to address this. We'll talk about per protocol or intention to treat analysis later in this course, and there's other time to event analyses that are discussed in other courses. But here I just want to lay the conceptual framework of thinking about competing outcomes in these different ways. So I come back to composite outcome primarily because a composite is an outcome that combines one or more of these other outcomes into a single measure. Sometimes that is the outcome of interest and what you want to study. Another reason to composite an outcome is if your event rate is low, you may need really large sample sizes or really long follow-up time to get enough events to really statistically study. We're going to talk about that in power and sample size a little more, but this is one way to increase your statistical and study efficiency by combining outcomes to increase your event rates. Sometimes it can provide a more complete assessment of association. You can combine competing outcomes to give you a more complete assessment of all the potential outcomes that can happen with a treatment or lack thereof. Sometimes you can combine a benefit and harm outcomes that help balance the risks and benefits of a treatment and give more complete picture in your results. So here's just an example of where the composite may be the outcome of interest. We're looking at tobacco-related mortality. Again, depending on what the investigator is interested in, you could be interested in COPD-related death related to tobacco. And if that's the case, then lung cancer and cardiovascular-related death, which are also caused by tobacco or risk is increased by tobacco, they become competing events. But say, for example, your study design is shifted or your interest is shifted, and now you're just really you're interested in tobacco's entire effect on mortality in a certain population. And then you would combine all of the biologically plausible tobacco-related death into one composite outcome. Or all-cause mortality is sort of the ultimate composite outcome. Sometimes you want to combine competing outcomes, so this is one way to address competing outcomes. You could combine all of these into one outcome, so that you would study anti-epileptic drug on time to first grand mal seizure, time to drug withdrawal because of side effects, or time to addition of another class, and those are all part of one composite outcome that is important to you. It gives sort of a more complete picture of sort of a failure of the drug. I don't really like this example that I made up, but I'll talk about it anyways. Here's where you combine a benefit and harm. Again, an anti-epileptic drug, let's just say, for example, it decreases grand mal seizures, but it increases GI bleeding. If your primary outcome were only grand mal seizures, you would show that there would be a decrease, assuming this drug works, and that would be your concluding line. However, maybe it causes an excess of GI bleeding. Well, if you combine those two in a composite, they may balance each other out so that the result, the concluding result of the trial, is that your anti-epileptic drug causes no difference in the primary composite outcome, increasing, although it decreased grand mal seizures, it causes an excess of bleeding, therefore sort of there's no difference, or there's equivalence. Probably a better example here is an anticoagulant or a blood thinner for risk of stroke, where it decreases the ischemic strokes but increases the risk for hemorrhagic strokes. So combining those two may balance or give a more complete picture of the benefit and harm of the blood thinner. Finally, we look at composite outcomes and combining a bunch of different ones. So let's say we have a lipid lowering drug. Our terminal outcome of interest is cardiovascular death, a pretty reasonable surrogate outcome, or is an important event. It's in the causal chain towards cardiovascular death, is a Q wave infarction. And then debatably, another surrogate that might not be as much of an interest is coronary revascularization, which also may be associated with additional confounders of whether or not an MD decides to revascularize somebody, and that could be subject to selection bias or other biases. So again, you're combining several surrogate or target or competing outcomes into one composite. And it's this final situation when you're combining different surrogates where you got to be a little bit careful. In this situation, the component outcomes you should consider are each of the components reasonably equally valid or important. If coronary revascularization is really not as valid an outcome or as important as an outcome as cardiovascular death, it could really muddy the waters in terms of the final interpretation of how to put these all together and combine them in one outcome. They should occur with similar frequency. So if coronary revascularization happens 10 times more frequently than death, again, it'll tend to really overpower and carry too much of the weight of the composite outcome. So they all should happen at roughly around the same frequency, so there's balance within the components of the composite. They should predictably, and you can't always know this, have similar risk reductions. Again, this just helps make the final interpretation of results more consistent, more uniform, easier to understand. If one is reduced by 4 times where other is only reduced by a small fraction, again, they often sort of carry an excess amount of weight and overpower the other components, and essentially potentially should be studied in isolation. They certainly should have the same underlying causal pathway, and hopefully not susceptible to different confounders. That example with coronary vascularization, there is an additional confounder to that component, which makes that one different potentially from the others in its interpretation. So these are just, these aren't necessarily have to be involved, but they help you produce a uniform and informative component outcome.